I am happy to kick off our first session today. It is high KDPI kidneys are improving patient lives. We are still working on one of our speakers, so we're going to kind of rework this a little bit today. The session will start with Nicole this morning, and Nicole Jefferson will talk about her kidney journey. Nicole lives in West Des Moines, Iowa. She was diagnosed with kidney failure in 2003. She was treated with in-center hemodialysis and peritoneal dialysis before receiving a new kidney in 2008. That kidney lasted 10 years, and then Nicole received her second kidney in April of 2020. Nicole has worked with many advocacy groups on Capitol Hill and has provided her personal experience with ESRD leaders in the field of nephrology. She tries to express the feelings of those who are unable or unwilling to speak for themselves. Nicole, thank you for being with us.
Thank you for having me, Jerome.
So, Nicole, let's talk about your transplant journey. What was the hardest part of the transplant experience for you?
Well, I think the first part of, with the first transplant in 2008, the hardest part was not knowing. I was thrust into kidney failure in 2003. I didn't know anyone, and I didn't have any knowledge. I wasn't able to reach out and, speak to people to find out how I navigate through this. So a lot of me going through this was just my own knowledge, my own, attempting to learn. And so I think that was the hardest part, is not really having the support of anyone who had been in this down this road before.
And what would you say was the best part of your transplant experience?
The second transplant that I received in 2020, I would say that was the best part. And the best part about that one is because in between the first one and the second one, I ended up meeting a lot of people on dialysis or with transplants or advocates. So I gained a lot of knowledge, and also with me speaking to nephrologists and speaking out, I had a lot more information. So I was able to go into the second transplant with information I didn't have the first time. So it wasn't, although it was emotionally draining at times, just having to go through a second one, it did ease up a little bit, just the fact that I had the backup, I had the support from other people in the kidney community, and also just the knowledge that I gained in between the first and second one. So that would be the best part about the transplant journey.
So what made you go out and seek organizations to belong to connect?
Actually, I was not even aware that there were organizations that would help and give that information. When I moved to Iowa, I didn't know anyone. I didn't have any connections. And somehow the Kidney Foundation reached out to me and asked if I wanted to go and speak, to Congress. At that time, I made that journey. I did that, and then I learned that there's a whole world of advocacy. There's an entire world out there of people trying to help with kidney failure. And that's how I connected with people and became an advocate, and I was able to learn about different organizations.
So how did you learn about the opportunity to receive an expanded criteria kidney or a not so perfect kidney?
With the first transplant, when they were going over all the options, that, things that would happen when I received the call, that was one of the things that they did discuss. They discussed that I may be able to get one that may not be an optimal kidney, but that they explained that although it may not be, people had taken them and they were doing fine. So they explained that to me, during the first one. During the second transplant, because I wasn't on dialysis when I started, when I had to receive the second one, my doctor expressed that he didn't want me to take one. He wanted me to just hold out as long as I could for a great kidney. However, it just kind of got to the end, and in order to avoid dialysis, I just did what was best for me, which was taking one of the high KDPIs. But each time I went to a center, and these were different centers, they did explain to me the high KDPIs and what that meant.
Yeah, so it seems like you got a lot of education around high KDPI kidneys.
Yes, I did.
Did you have any fears about getting a not so perfect kidney?
Um, the first time I did, actually both times. My first time I was nervous, but you have to think that was my first transplant, so I was nervous about anything. I was nervous about even having a foreign object inside of me. So of course, one that wasn't so great, I was even more nervous about, and I was thinking, what is this going to do to me? What will happen? So I was nervous. The second time, I was a little nervous because this one had some attributes that weren't so good. However, I just, had to take a step back and say, you know what? I don't want to go on dialysis, and I want to, I need another kidney. And I just got to thinking, you know what? They say it's a high KDPI, but how do we know that other ones aren't necessarily high KDPI? The second one was a high KDPI based on the information that was provided by the family of the donor. And I just thought to myself, I was glad that they provided that information, but even with living donors, they may exclude some information that they don't want known. So I wasn't as scared that second time, I don't think.
Okay. And how did your family and caregivers, the support staff play a role in getting you transplanted and, transplant wait list ready?
Um, well, I will say that the the first transplant, of course, it was my first one, and I had an awesome nurse who walked me, and an awesome nephrologist, and they, wanted to take me step by step into everything that was happening. The second transplant that I received, I had more knowledge, so I didn't need the hand holding, but they still did that. One of the things that happened with the second one is I had by then I was living in Dallas, and so I had to fly to Des Moines. So of course that was a lot of hand holding to get me from Dallas to Des Moines in 5 hours to get this kidney. So they were very supportive in that. They were supportive in, when I was trying to get on the list, coordinating with insurance, also making sure that all of my testing was done. They were able to accept my testing. And if there were any issues, we sat down and we discussed why it was an issue. And they were even able to reach out to other doctors and say, this is an issue that we have. Can we work around it? So I will say that both transplant centers that I was involved with were really good about, helping the patient and being there.
How might providers, because we have several providers on the call today, how might providers educate patients about expanded criteria kidneys or less than perfect kidneys in order to increase the number of patients who are transplanted?
I think one of the things that you know, the centers need to do is make sure they are discussing it. But, in this day and age, we want to defer everything to the internet, defer everything to, oh, we have this on our website. But with something as important and as touchy as this, I think the patients need to be able to walk away with something. Because immediately, if you hear the high KDPI and you hear all of the things that could be wrong, some people automatically turn it off, the thought process. But, if they are able to leave and have something to look back and, digest later, not in a clinic setting, then I think they will be more apt to take these. Also, referring them to other patients who've had high KDPIs, transplants, and have been successful, and people who don't regret it.
Yeah, so kind of like a patient navigator.
Yes, yes.
So what advice would you give a care provider working to keep patients on, the transplant wait list and transplant ready?
Oh wow. I would, one of the things that I think a lot of what I've noticed a lot of people, a lot of patients have problems with is not letting the care team know when there's something going on with them. If they have a cold, if they have any type of infection, if they're in the hospital, I think the caregivers need to make sure that they're letting the patients know if there's any change in your health, any change with anything that's going on, you need to notify us. Also, making sure that they're aware of every test they have to take in order to be listed, because some of those things, you would take before anyway. But just making sure they're aware this needs to be taken. And I think another thing is explaining to patients why these things are needed. One of the discrepancies that I saw on Facebook was a lady being upset because her son was not able to be listed due to dental issues. And no one explained to her in her clinical setting, the importance of having the dental clearance. And so she had to come to the internet to find out, in Facebook, to find out why it was so important. And she found that out for patients. So I think if the caregivers are just upfront and explain the reason everything is needed, it would make for a better patient experience, and also a better partnership, because we have to realize, and doctors have to realize, that this is a partnership. We're in a partnership to try to make sure that we get better, that we're able to get transplants or go on whatever modality of dialysis that we want to make sure that we have the quality of life that we're looking for.
Thank you, Nicole. I'm going to ask you to hold on because towards the end of the program, I'm sure our audience members will have questions for you.
Okay.
Next, we want to go to Tina Dinkel. Tina, who is the project director for the ESRD Treatment Choices Learning Collaborative, or ETC-LC. The collaborative is one of the largest of its kind, working to get more patients on the kidney transplant waitlist and ultimately transplanted. Some of you who have been in the ESRD network world for a while may remember that Tina served as the executive director for ESRD Network 12 for more than a decade. She is a former board member of the Forum of ESRD Networks and Explore Transplant. As a donor daughter, she is an advocate for organ donation and passionate about healthcare education. Hi, Tina. Thanks for being with us.
Jerome, thank you so much for the opportunity to present to your group today. And Nicole just wanted to share Melissa's expression in the chat too about sharing not only your story, but reminding all of us this is a partnership and we all have a role. So I appreciate your passion, as well as how informed and educated you're advocating others to be about their situation and sharing your story specifically about KDPI. So thank you so much. I'm going to kick off today. As Jerome said, I'm the project director for ETC-LC, or the ESRD Transplant Choices Learning Collaborative. That's a mouthful, I know. So I want to just give you some context if you haven't heard about the program, and how long we've been around, and some of the work that we're doing to try to partner in this space as well. So I love this slide because I think it gives us all a reminder of all the programs that are available in our ESRD community and how many organizations are serving patients and providers around the country, and the important work that they do, how it comes together to increase transplants. So obviously, many of you may be aware of your local ESRD network in your region, of which there's 18. So just talking a little bit there on the far left there, some of the work that they're doing within their coalitions in their individual networks. We also have the ESRD Treatment Choices Model test for incentive, which is around payment and reimbursement. Then some of the crossover or the bubble overlaps here. You can see NCC, which is what Jerome and Stephanie, as well as Julie, are involved in. and bringing forth information to the community as well. And then the yellow bubble on the far right bottom is the work of the collaborative. So again, increasing transplant, decreasing discard, and increasing utilization of KDPI kidneys. So currently, on the next slide, I'll share with you a little breakdown. It's busy, but I think it's very valuable because it gives you each of the individual entities, if you will, or the groups that we have working in this space. So the ETCLC community as a whole started with a change package series that came out right before COVID began in March of 2020, after about 18 months to 2 years of background and research between transplant centers, donor hospitals, as well as the organ procurement organizations, or OPOs. So from that change package, the ETCLC started. So we utilize that framework to bring together our national faculty, which is our leadership. Then we also have our LCC, or Leadership Coordinating Council. Many of those organizations, there's 24 currently, entities like AAKP or dialysis patient citizens, and other organizations, including NKF and others, so that we have a oversight group that we bring information to. Then we have our SMEs as well, our patient recipients, and also donor families, because we work again with hospitals and with those donor families specifically. In addition, the primary or foundational groups that are part of the ETCLC are our quality improvement teams. So those are made up typically of anywhere between 18 to 35 professionals, again, from those donor hospitals, those transplant centers, and the OPOs, or organ procurement organizations. There's a coach for each of those teams. And most importantly, within those teams, we do have a PFR, or our patient or donor family representatives, to always provide that patient perspective. And I'll share a little more about the work and insights that those individuals bring as well. So part of our work through the ETCLC not only involves those individual teams, but we have very specific aims under our CMS contract work. And over the next 5 years, we will be updating the change package based on some of the great work that's taking place in the teams and some of the best practices that come forth out of that work. So on the next slide, I'll share with you specifically those aims that we are working towards. So we just started year 2 in August of this year. Again, this is a 5-year project. We are on pace to meet aims 1 and 2, which again is focused on increasing transplant and increasing utilization of those high KDPI kidneys. And we have a lot of work to do around the discard rate. So we are focusing more on that through the year. And this just gives you a visual of exactly what the outcomes are that we're looking for in those goals over the next 5 years, as well as where we are. Very distinctive, on pace to meet 1 and 3, and then working towards decreasing the discard rate over the next 5 years as well. And so on the next slide, I want to talk a little more about our quality improvement teams, as I've pulled out here on the left, giving you some specific information about how each of those teams are made up. But more importantly, knowing the work that they're doing around quality improvement, but also identifying the best practices, specifically what is working in their organizations, teasing out more of the details and how they do the work, how they measure it, and then spreading that to other organizations is a huge part of that work. These groups do meet on a monthly basis, and we also offer weekly calls for case study sharing, as well as pacing events. Again, teasing out what works and what they're doing, their organizations, to move that energy forward, if you will. So again, we do have a transplant recipient on each of our donor teams, and then we have a donor family representative on each of our transplants teams. And the work of those, on the next slide, I'll share with you some of the great activity that's taking place, is obviously, like Nicole did for us today, and Janice will later, is providing their lived experience, to be able to share that with the day-to-day professionals, the operations folks, administrative, surgical teams. The makeup of those groups is vital for their understanding of the impact that they have and the real life person that is in receipt of that gift of life. and specifically within the community of the kidney world. So being able to share that lived experience, being able to provide their insight and family experience, or what Nicole's done today with sharing her role as an advocate and being part of the team between her surgeon, her nephrologist, and so forth, reminds all of our professionals in this space of the great work that's necessary and the great work that we have yet to achieve. So additionally, some of the insights related to waitlisting, how they were managed, how things were coordinated. Nicole specifically talked about flying from Dallas back to Des Moines for her surgery and all the coordination that takes place around that, how important the communication aspect is, again, on both sides, from the professionals and the clinic managers down to the family help and support of each of our patients and recipients. And then obviously process enhancements. What can we do better? What would you change? And I believe Jerome did a great job of this, is starting out is what were you most nervous about or wish you had more information than what went really well. So on those monthly calls, they do tease out some of that information as well. And then just having a patient on the line to answer specific questions about the experience, about the ideas and the suggestions that are coming from each of these teams. So very valuable part of the work that's taking place in ETCLC. And then I'd also like to share with you a little bit of information about what's next, what's coming from ETCLC on the next slide. So as I shared, we are just in our second year. This is a very early on program. We have spent the first year getting started, organizing all of our teams together. And again, this represents approximately 80% of all the transplant centers in the U.S., as well as 93% of all the OPOs. So the depth of this particular collaborative is significant. And we look forward to, again, increasing our transplants, utilizing high KDPI, greater around the country, as well as decreasing discards. So as I'd mentioned before, we are focusing more on that. AIM 2 specifically are decreasing discards as a collaborative. So you'll see more work around that. We're going to be doing some kickoff work this month, as well as into November and December with our individual teams. Again, the focus of the PDSA, the testing, what works, how they're doing it, how they're measuring it, and who's involved in those initiatives at the OPO transplant center or donor hospital. And then adding our ESRD network partners. They've been a great factor in the work that we've done so far, but taking advantage of the transplant coalitions that are active in their individual networks, bringing those together so that we're not working separately and finding ways to complement each other. Those may include things like resources that we can share throughout the country instead of just in an individual network. Those may include opportunities to speak and present on the work that's taking place in individual networks and bringing that into the collaborative as well. Again, just to share ideas and what's working. Focusing on our health equity work, and then potentially bringing in patients that are either late stage, as Nicole, I believe, mentioned earlier before she started dialysis, and providing some additional insights, education, and information to those folks as well. What we'll be doing with the change packages, again, I mentioned earlier that the ETCLC started out of that change package work and the opportunities that were identified there. We're also going back now 3 years later, interviewing our high performers now, especially post-COVID, since the change package did not include any of those strategies or how organizations were working in a COVID environment. So going back and re-interviewing and taking a look at the data so that we can identify those high performers. We just completed the work with our organ procurement organizations, and those interviews are complete. Now we're moving on to our transplant centers and identifying those high performers. So we'll take that process. It's approximately 6 to 8 weeks by the time we start the interview process, collate all the information, pull it together, and identify the key insights, and then bring that back out to our coalition and collaborative partners within the ETCLC. So additionally, on the next slide, we are continuing our pacing events and case studies. Those happen almost every Wednesday. I think there's maybe 2 or 3 Wednesdays that we don't offer a program, but again, bringing those real world sharing sessions or sharing opportunities so that peer to peer at these organizations, they can ask each other questions, they provide insights, tips and ways that they're changing and improving not just their outcomes, but their patient experience. Has been a significant insight this year. And we've just started, again, remember, we've just started our QI teams back in the spring or first part of 2022. So now the work that they've done just in this short 90-day, 6-month period, being able to bring that information back to the collaborative in a meaningful way, and then incite some ideas and new sharing has been a treat to see over the last just 2 months here into this year's programming. Another way that we are sharing out some of those insights is through our monthly communication that we're referring to as Everything ETCLC. So we know that our partners can't make every single call. They may miss a QIT meeting, which is their priority, but being able to share out resources, key informations, quotes for the month, an update on where we are in the aims, so that is available to the collaborative as well. And then we have our educational collaborative that we're just starting work on with your NCC partners today, who is hosting this particular session. And our tackle contract, it's the ETCLC contractor, which includes myself. So our teams are coming together to talk more about those high KDPI or non-standard, less than ideal opportunities for a better than dialysis experience through kidney transplantation. So these are some terms here that I'm sharing, and one of the great ones I've heard is it may not be a perfect kidney, but it's perfect for me. And I think that's some change and shift in our environment, in our community, that will be welcome in the next few years, especially as you hear more about about other transplant recipients and the great experiences they've had since receiving their high KDPI or, quote, less than ideal kidney. So looking forward to more communication around that, more education. And I know there was a question in the chat earlier, so I did want to just kind of touch on it for just a moment. What is KDPI? It's and again, Melissa Dorsey from CMS shared this in the chat, but the numerical measure that combines the 10 donor factors. And for those that may not be aware, that's things like age, height, weight. Is there a history of diabetes or cardio or hypertension with that particular kidney? So it gives a range, if you will. And so ideal, it's less than 20. But again, in this collaborative, we're targeting greater than 65 as that final number, as an opportunity to share and get folks transplanted more quickly and increase their quality of life as well. So finally, I'll wrap up with you today, just sharing on our last slide here a couple of our upcoming events. And again, these are public pacing events as well as case study learning opportunities. You are welcome to go to the website here, or I do want to announce as well that we have secured a website, and it's simply etclc.org. So again, etclc, the last 5 letters there, .org, for more information about our collaborative and the work that we're doing. We try to keep that updated every month or 2, especially as quickly as we're seeing the numbers change in our 3 aims. So again, etclc.org, I'll probably just drop that in there. You can keep that close and take a look at what we're doing in between calls like this and updates from the transplant community. Jerome, thanks so much for the opportunity to speak today. And I believe you have a polling question for the group as well. Thanks, everyone.
I do. Thank you, Tina. Lots of great information, and the collaborative is doing really great work. So, and I'm proud to be a part of it.
Yes,
so,
thank you, Jerome, for all your coordination too with our patients and SMEs. We are incredibly grateful. Thank you.
Thank you. So we do have a polling question. Let's see if I can get this up and working. And the question is, do you know someone who received a not so perfect kidney? And I should be able to release this poll, but options. I see I'm getting a lot of responses in the chat box, and a lot of yeses and a lot of nos. But a lot of no's, but I'm glad that hopefully this session is at least educating a lot of folks about the opportunity to receive a less than perfect kidney. So thank you guys for responding to our polling question. All right. So we heard from Nicole. We do want to hear from Janice. Janice, thank you for joining us. Janice is a native Floridian. In fact, she is from my community, actually, the city of St. Petersburg. She was diagnosed with ESRD in 2000. She has treated with in-center hemodialysis, peritoneal dialysis, and home hemodialysis.
Yes.
Janice received a kidney transplant in December 2013. She is the founder of All Kidney Patient Support Group. She works at her family's child care center. She's a volunteer for LifeLink Tampa Bay, which is an organ procurement organization, and she volunteers for several other organizations. Janet's lifetime goals consist of bringing about continued awareness, education, and advocacy for end-stage renal disease. Janice, welcome.
Yes, I am so happy to be here. Let me turn my screen back on. Yes, okay.
Okay, we can see you, yes.
Yes,
So,
happy to be here.
Janice, what was the hardest part of your transplant experience?
Getting on the transplant, because it's kind of a dual thing about my transplant. First of all, I had to lose weight. So that was one of the, I mean, you want to know about the transplant experience, my experience right now?
The
Kind of before and
the journey of getting a transplant.
Okay, well, the journey started with me. First of all, I had to lose weight, and a lot of people don't realize there is a weight criteria for getting a transplant, and which I didn't know. And I remember when I first was diagnosed with kidney disease, my doctor said 20 pounds and you can get a transplant, and I did not understand what he was saying. But now, once I was, on dialysis, and he said, "Janice, you got to lose weight." That was one of the hardest things for me because I love to eat. But now I'm in a new mindset, and eating is not I don't love it. It's another way of life. But that was the hardest part. Keeping my records was another hard part. It was back in almost 20 years ago. They didn't have the computers and everything, the my charts and the different portals, patient portals. So everything was done on paper. So I had to walk around with a big stack of paper, a folder from all of my doctors to make sure that I had all of the lab works. And another thing that was hard about my transplant was getting listed. Because of my weight, my local transplant here in Florida, in St. Petersburg, Tampa Bay, they wouldn't list me. So I had to go get listed in Gainesville and Miami. And I had to coordinate all of that paperwork between Gainesville, Miami, and TGH. So that was the hardest thing, keeping up with all of the information that I had to do. And
what would you say was the best part of your transplant experience?
Freedom, the freedom to travel. I love to travel. I travel with my own dialysis, but I took my machine with me, and I had to make sure I had a lot of tip money for carrying my home hemo machine through the airport. But the freedom of being able to move, to get up, to be able to go. I've been to Italy. I'm trying to go to Africa, but now I'm thinking about that the yellow fever shot that I just found out a few days ago that transplant recipients are not able to get that yellow fever shot. So now I got to find out what else can I do, because I would like to go to Africa or other countries. So traveling, freedom, that's my biggest thing.
So I understand that you received your kidney from a man that was in prison, and was considered expanded criteria kidney. Did you have any concerns about receiving a kidney from someone that was in prison?
Well, when I first heard that he was in prison, I was kind of shocked when they first called me. But afterwards, it was like she told me he was 33 years old. And I was like, well, he wasn't that, he was young. He was young, but he was in prison. She said he was in and out of prison. And so one of the things that I thought about, I was like, well, he hadn't been in it that long. They said, well, he could have a case of hepatitis, but it wouldn't be bad. But I said, no, I've waited 14 years. I need to go ahead and get a kidney. I had waited so long. I was just ready. Go ahead, let me try it. I was ready to take it.
Yeah. Did your family members have, because I know you're close to your families, did they have any objections to this, or were they supportive?
We all kind of talked about it. They was like, well, he was in prison for what? I think it was 8 months. And then they was like, well, his kidney is in his body. What else could happen? Let's just go ahead. We'll worry about get the kidney and then we'll worry about the rest later. And that was one of the biggest things that, because one of the things that my sister told me, even before when I was signing up for the list, I broke down crying in the waiting room, and because they say I didn't have enough money. And that was another big thing. I'm kind of retracting, and I just remembered this because my sister was the main part who told me, don't worry about the guy being in prison now. Let's just get the kidney and we'll live life and think about that part when that part comes. So she had to do the same thing with me when I was in the transplant office signing up for my transplant. They told me I didn't make enough money. I need to have $5,000 or $6,000 in the bank, and I couldn't have it, and I only had Medicare, and I had to have the 20%. And I just broke down crying, and my sister said, look, you have family support. You have your church supporting you. We'll write letters that we're going to get support, and we'll worry about that part, the money part, later. So that was another big hurdle that they discouraged me from getting a transplant because they say I didn't have make enough money.
Yeah. So did you have any pre-education about, expanded criteria kidneys or high KDPI kidneys?
I had none other than sitting in the doctor's office for my yearly transplant workup, and the guy was saying at year like 13, well, have you ever tried about getting a criteria kidney, a KDPI kidney? I said, a KD what? I don't even know what you're talking about. And he was like, well, you can get he broke it down this way. You can get a kidney that's somebody that's older, or you can get a kidney from somebody that's younger, or, somebody that has been, high blood pressure or this. But right now, and so that's how he explained it to me. He had to break it down because I was like, I didn't understand. And me and my husband looked at each other at the time, and we said, no, we want a good kidney. We didn't want a kidney that was damaged. And that's pretty much what he said. And I was like, no, I don't want a damaged kidney. And so, but once I got to the year 13, I was like, yes, give me the kidney and let me worry about that part later. So I didn't have much education. I did not understand what they were saying because it was in Miami. And also another part, the language barrier in Miami, because most everybody in Miami speaks Spanish. So I got my transplant in Miami. So it was another language barrier there also.
So what advice would you give like a care provider working to keep patients on the transplant wait list? What's the best advice to keep patients, transplant ready?
First of all, you need a person that is empathetic, sensitive, and caring. I remember the lady was matter of a fact. We do not need type A personality people working in the transplant. for people signing up for a transplant, because she just said you don't have enough money, you can't sign up. And I'm finding that to be the case with a lot of people today. If you don't have insurance, you can't get a transplant. They just tell you point blank, and they don't have any, well, you can get a transplant, but there's something else you can do. They're just making it this statement to people, and they just made a statement to a young lady the other day. If you don't have money, if you don't have insurance, if you don't have this, you can't get a transplant. So we need people that are more compassionate, that's willing to say, you can get a transplant, but you need to have this, but there's ways to go around that. There's ways to work within the system. We don't need somebody just telling you, no, you can't get this. And then you go home and you cry, and then you go to depressed, and you realize that, no, you can't. I'm not able to get a transplant because I don't have money, because the color of my skin, because I don't have this, because I don't have that. And it makes you feel depressed. You get depressed.
So more compassionate folks.
Yes.
I want to bring Nicole back into the conversation, and I also want to open up the lines to questions from the audience. So if anyone has a question for either Tina, Janice, or Nicole, please use the WebEx chat feature to send your question in. So my first question is for Nicole or Janice. What are some of the things that you are doing to maintain the health of your kidney?
Oh, wow. I'm just making sure that I am taking care of my body holistically. So not just making sure I'm going to nephrology appointments, but I'm also making sure that everything, that I don't have any type of infection. So I make sure I go to a podiatrist. I make sure I go to the dentist 4 times a year. ENTs, just anything that I can make sure everything is taken care of in my body, so there are no issues with the kidney. And of course, making sure that I'm taking my medication every day when I'm supposed to take it.
I'll agree with Nicole, making sure that I'm taking care of my body, eating correctly. I just started learning that not eating a lot of beef is better for my kidney, and watching all of my labs, not just the kidney labs, but making sure that I look at all of my lab work, and noticing that when I eat this, my labs come out this way. When I don't eat this, my labs come out better. So being more proactive with my lab work, being more proactive with what I put in my body, being more proactive with exercising. I've almost lost like 25 to 30 pounds in the last, this year, and I feel better. And exercising, it's a wonderful, I never thought I would like to exercise, but I do. I really do.
And Tina, this question is for you. If an organization or a patient wanted to be involved in the ETC-LC, how can that happen?
Great question. Thank you. Because I know we have a lot of amazing advocates and patients that are on the line with us, as well as other folks in the community. So the fastest way to get a hold of us is to reach out via email. And that email I will drop in our chat today is tackle, TAQIL info at hsag.com. And we'd be happy to talk to you about ways to get more involved.
Thank you, Tina.
Jerome.
Question for Janice. Did the letters from church and community promising financial support help you qualify?
Yes, they did. That was the only way I qualified, was to have the letter, and it had to be a notarized letter from my church and my family stating that financially they would support me through my transplant. Yes, that's how I was able to get listed.
And question for both Nicole and Janice. What advice would you give to someone thinking about getting a transplant but has, concerns?
Nicole, you want to go first?
Sure. I guess I would ask, what are the concerns that you would have? because is it financial? Is it a financial concern? Is it a health concern? I know a lot of people don't necessarily want to have a surgery, is what they call it. So I would question what the concern is. But whatever those concerns are, I would suggest reaching out to people who could tell you about that particular concern and going from there.
Great, I agree. What are your concerns? One of the things that I would, um, if you are ready to get a transplant, if you're tired of dialysis, the transplant is the way to go. But then some people are happy on dialysis, so it's what would you like to do? Like you said, what are your concerns? What do you feel? Do you feel that you're capable of having a transplant? Another concern, Jerome, I hate to say this, but the transplant center require that you have a care partner for 28 days, the first part of a transplant. And I'm finding that a lot of single people are concerned about having a care partner, people that are, especially here in Florida, we have people that are from other families that live in Illinois or family that lives in other parts of the state. So that's a main concern. If you're a single person and you're on dialysis and you wish to get a transplant, what you would need a care partner. So that's another issue that they need to think about also.
Thank you both. There's a question that came in the chat. What kind of insurance did you have at the time you received your transplants?
When I received my transplant, I had Medicare and I also had private insurance. However, when I was first being listed, as Janice said, I only because I crashed into dialysis, I didn't have even the Medicare at that point. So I also had to get a letter from my family, and they actually had to show each center is going to be different. So my family had to show that they had whatever it was in the bank that would allow them to be able to pay for my meds. But I had, and I worked, and when I received both transplants, I'm working for the same company. I've been with the company for 16 years. So Medicare, of course, was primary, and then my private insurance was secondary.
Thank you.
Yes, I just had Medicare, just like Nicole did. I just had Medicare, and once I got I was on dialysis for a while, I was able to get the supplement insurance. And they told me the day that I got my transplant that the supplement would go away. So that was true. The day I got my transplant, the supplement did go away. So I had to pay for that, my supplement out of pocket. So I only had Medicare. That was it.
Well, Nicole, Janice, Tina, thank you guys very much for being with us this morning. We definitely appreciate you sharing your experiences and all that you do for the ESRD community.